So ask me anything, Monday night, 6 p.m. Central Time, Dr. Twyman. So hope you guys had a great week. Had some good questions tonight. So we'll lock and load and start them up. So first question up tonight. So torn on if I should take a statin. I'm a 43-year-old woman with a calcium score of 69, no symptoms. Eating plant-based. So the calcium score test is the kind of the tiebreaker. If calcium score is 0, you're low risk. Your risk of a heart attack over the next 10 years is less than 2%. But if your score is between 1 and 100, your risk is over 4% over the next 10 years. So you're trying to reduce risk. That is why a statin would be considered. Now, it's not the only tool. It's just one of the tools. You have to optimize nitric oxide. You got to keep oxidative stress and inflammation low. And then you got to work on the lipoproteins. So plant-based, that's okay. Just make sure you're getting enough omega-3s through some source, and that you're also getting your protein, your iron, your B12, and such. So no concerns that it's necessarily plant-based, but the statin is irrespective of what your diet would be particularly. So Boston Heart Lab panel could help guide you, would help you understand if statin, statin's the best case use, or potentially consider ezetimibe. All right, next question up tonight. How do you reverse plaque buildup and break down blood clots in the arteries? First, you got to get to the root cause of what's driving the plaque buildup. For the quantum biology people watching, it's a collapse of the structured water or the easy water or the coherent domains, however you'd like to call it. But if the glycocalyx, which is full of easy water, collapses, then you're set up to develop the plaque in the arteries. So you got to repair that. So grounding, infrared, some things that potentially help improve the easy zone, UV light as well. And then supplement-wise, there's things that can support nitric oxide. There's things that can support the glycocalyx. And then use whatever tool you need to get the lipoproteins in check. I usually shoot for a target goal of an ApoB of under 70 and an LDL particle under 1,000 if you already have demonstrated that you have plaque in your arteries. As for the clots, sometimes that's due to the structured water breaking down and then clotting factors getting activated from the glycocalyx, so fix that. But if you have high fibrinogen, consider things like statins, grounding, nattokinase. What's most important for APOE4? To understand that it's not a issue where you have the gene and you automatically get some type of disease. It's not Huntington's disease where you have the gene sometime in your life. If you live long enough, you'll develop Huntington's. But APOE4/4s, they have at least a 10x fold increased risk of Alzheimer's, increased risk of diabetes. Lipids abnormalities are common, and statins tend to not work as well for APOE4/4s. So keeping inflammation very low, avoiding insulin resistance like the plague. But really, it's keeping DHA levels optimal. You're much more at risk of having inflammation in the brain. You need omega-3s to help mitigate that. So seafood is your best friend. What is inflammation and how does it relate to cardiovascular disease? So the short answer is too many protons, not enough electrons. But, in English, your immune system, you want your immune system to kick on when you got an infection, you have an injury, you want the body to repair itself. You don't want your inflammation from your immune system to be turned on all the time. Oftentimes, oxidative stress drives inflammation. Think of it as fire. If there's fire, you're more likely to damage the glycocalyx and the underlying endothelium. You damage that protective coating. You're off to the races to potentially developing inflammation in the arteries and plaque in the arteries. How does non-native EMF damage the glycocalyx? It's through the voltage-gated calcium channels being opened up by the EMF. That causes a cell danger response that drives oxidative stress and inflammation. And inflammation, oxidative stress directly damage the glycocalyx. Can depression and anxiety cause heart palpitations? Yes, indeed. If you have high stress hormones, high cortisol, that definitely can drive palpitations. Next question up. What is the best way to prevent LDL? I don't know exactly what you mean by that question, because you don't necessarily want to prevent LDL. LDL particles are just transporting your cholesterol, triglycerides, fatty acids, and phospholipids through your lumen. But you're probably, if you were able to add on, would be how do you prevent the LDL from damaging the arteries? So I'll finish that part of the sentence. Well, keep your inflammation, oxidative stress low. Keep your nitric oxide optimal. And then use whatever tool you need to keep the lipoproteins in check. Question, is it okay to eat eggs daily? This is not medical advice, but for most people, generally yes. But if you're one of those people that when they eat eggs, their lipids significantly increase, then you might have to mitigate some of the eggs by eating less, or consider a medication like ezetimibe. But most people are generally okay, myself included. Does plaque get deposited all over the 60,000 miles of blood vessels, or is it preferred places? Great question. It typically is at branch points, so where arteries, are splitting off. That's why often, if you have a calcium score test, typically it's the left anterior descending artery. I don't like the term, but the Widowmaker artery. There's a lot of diagonal branches and septal perforators that come off the left anterior descending, and so wherever there's those bifurcation points, think of like a river has a side branch. There's eddy flows of current going down those side branches, and those eddy flows damage the glycocalyx, and then plaque builds up in those locations. But you don't always develop plaque equally in the carotid, the coronary, the iliacs at the same time. So that's why you had to do serial testing and kind of head to toe look for the plaque and where is it most significant. But the treatment is relatively the same. Find what's causing it and pull back on those levers. All right, next question. When we try to clean out plaque, how does that actually happen? The plaques delipidate, the soft caps become firm caps, the smooth muscle and the calcifications are deposited. But basically, to simplify it, just think about, stop doing the damage. The body has innate wisdom and will be able to take care of it. So when I regressed part of my own plaque, that's what I did. I made sure my nitric oxide levels are high. I took a glycocalyx promoter, and then Kylo garlic also has some data at helping stabilize plaques. So garlic is anti-inflammatory. That's probably one of the reasons it works, but it also is heavy in sulfur, and the sulfurs are then donated to the glycocalyx. So you're building up more easy water, more coherent domains. So stop doing the damage. The body knew what to do. Plaque starts to regress. In part, HDL goes in there, grabs some cholesterol, and pulls it out. That's one of the roles of HDL. All right, and we got two more pre-submitted questions. All right. Somebody's asking, is CBD oil bad for the heart if taken for chronic pain, spinal fracture, and sleep? It pretty much depends on if there's any THC in it. There is data that can increase atrial fibrillation, can increase triglycerides, and what is the route of administration. So you definitely don't want to be inhaling anything that is going to be into the pulmonary circuit. If it's a edible, or oil, less likely to be problematic. But you would have to talk to your doctor, as it can interfere with anything else that you're taking. All right. Question, how does one tell if living a circadian lifestyle is, quote, working? Any markers that I look at? Not necessarily blood markers. Most of the time that you're leading a circadian lifestyle because you're doing the things you would need to do to keep your circadian rhythms in check. The two main zeitgebers are the light that enters your eyes and the timing that the nutrients come into your GI system. Food's an easy one. Your liver and gut need at least 3 hours to shut off from when nutrients come in. So ideally, whenever your bedtime is, back it up 3 to 4 hours and don't put any food in the system at that time. The other short way to think about it is if it's dark outside, you're not optimized to be eating, so try to eat during daylight hours. The light one is slightly more challenging to explain, but if you've been following me for any length of time, unless you've met me in person, and I'm outside or I control the light environments, you've never met me without these glasses on. So I'm very militant about controlling my circadian biology. So don't miss a sunrise. If you're inside and don't control the lights, wear your blue blockers, the yellow tints during the day, sunsets. If you're not too sensitive, you can throw the red ones on at that point, the red lenses. But I'm very sensitive. I'll be asleep in under an hour if I have the red lenses on. So I usually only wear them about an hour before bed if I need to be in bed at a certain time. But most of the time, my sleep's so dialed in, I don't necessarily need them. Now, markers. One thing you can look at is you can look at your sleep scores. So I often wear an Oura ring to track sleep. You look at your HRV. And then other markers, I talked to a patient today, was having some glucose regulation issues. Very good nutrition regimen, very good at his exercise routines, but maybe a little bit lax on some of the light hygiene. So it's going to work on his light hygiene and see how does that affect his glucose. So he's going to be wearing a continuous glucose monitor to see. So you might see better glucose control if you're leading a circadian lifestyle. All right, a question is 5 milligrams rosuvastatin help lower LDL or stabilize cardiac plaque if only taken 2 times a week? It has not been studied for that indication. For the plaque stabilization, they're always looking at higher doses in those studies, usually at 20 or 40 milligrams of rosuvastatin. But from a lipid lowering standpoint, yes, I've definitely seen twice a week administration of rosuvastatin have a pretty good effect for many people. Not everybody can tolerate higher doses or tolerate it daily, mainly due to muscle symptoms, muscle pain, muscle weakness, muscle damage. So the plaque stabilization was always studied at daily doses, from my understanding. But doesn't mean that you shouldn't try it. Just because they haven't studied in large populations doesn't mean your N of 1 won't work for you. So I still often will do it for patients, and then I'm following their carotid intima-medial thickness scans yearly, and then potentially, if they've had clearly CT angiogram, usually 1 to 2 years later, we consider repeating a clearly CT angiogram at that point to look for plaque stabilization and optimally plaque regression, or at least partial regression. All right, and I already answered that question, so I think I got through all the live questions. So thank you guys as always for submitting those. Those are some great ones as always. I'll glance through the comments and see if anything else is popping up in there. And then did want to update you that I finally did get all my old IG live archives transcribed through this AI app, and then have uploaded them to my YouTube channel. My YouTube channel is just drtwyman.tv, or you can go to youtube.com at Dr. Twyman, spelled just like my Instagram handle. So my old IG lives are there, and it puts it in the description, the questions, so you can skip ahead and look for the questions and answers that you're interested in. But that's where all these archives will go. And then the goal this year, now that I got the new kind of studio getting set up in my space at Apollo Cardiology, where I can be able to do a little bit more long-form content there. Somebody's asking, can rosuvastatin cause insulin resistance? It can contribute to it. The only statin that really does not do that is pravastatin. But rosuvastatin generally does not as much. It typically is more atorvastatin or simvastatin. But it's not that you become fully insulin resistant. It's that it starts increasing glucose. And it won't take somebody who has normal glucose and make them diabetic. It raises the glucose a few points, but often you're getting the benefit of lowering inflammation, plaque stabilization, and then maybe getting you to your ApoB targets. But if it's too big of an issue, then you can switch to ezetimibe, PCSK9 inhibitor, or Nexletol. And you're very welcome for answering your question. All right. Well, this might be a little bit of a short one tonight because I think I powered through a lot of these questions in order. So if anyone pops up in a moment, I'll take it. But if you have any other feedback, always happy to hear it from you guys. If there's something in long form content you want me to put together, send me a message and I'll add it to the content idea list. I've been on social media putting content out for at least 5 years now. So if you just put my name into a Google box and search for a topic, you're likely to find at least one of my ideas on it. There's not too many ideas that I have that are completely out of date. If you look at some of my old content, there's some minor stuff that might have tweaked or might would have optimized. But if you go back and look at my old LPA talk from 2-3 years ago, it's still very on point. The only thing I would change is the drugs are now finally almost to market. But if you're into some of those type of topics, then just drop them in my comments. So, all right, guys. Well, I hope you guys are having a great week. I'll be back next Monday, 6 p.m. Central Time, as always. You can check out my YouTube channel, drtwyman.tv, and I hope you guys send me some feedback that I can do something for you on that channel sometime. So take care.